from all indications, without having any imaging data, this patient appears to have locally advanced contiguous disease. It's been my experience in the patients that I had in the phase 2 pivotal registration study that the vast majority of patients with locally advanced disease have significant response, and some of them had complete responses that were durable. So my anticipation is that within a few infusions, the patient would have symptoms decrease. That would be decreased pain, and then within more infusions that you clinically see an improvement in the lesion in terms of a smaller diameter, potentially filling in of erosion, and these visual improvements. Immune-related adverse events in patients taking systemic anti-PD-1 therapy are most commonly found either to be of the thyroid, so having a thyroiditis and having some hypothyroidism as a result, GI consequences, and some people get mild GI adverse events such as some upset stomach or some diarrhea. There are some people that have reports of some fatigue from time to time. When they're not overly active and bouncing off the wall, they can feel kind of fatigued. Those are the more common ones. Rash that's low grade, non-blistering rash is another one that I've seen in multiple patients. Some of them just are self-limited and they resolve on their own. Some of them we intervene with either topical or systemic lower dose steroid for the most part, because we're talking about lower grade adverse events. I have had some patients with the higher grade adverse events, including immune-related bullous pemphigoid, where the patient had a large number of bullae, which we started the patient on a systemic steroid dose and then tapered slowly as the skin improved. And those are the types of adverse events that are the more common ones. Of course, any organ or tissue can be involved, and usually the diagnosis ends in itis, but not always. So you can think of them as an inflammation of basically any part of the body. Those are those other than the ones I've already discussed are the less common immune-related adverse events. To manage immune-related adverse events, it's important that the patient be seen early. That's why I stress repeatedly with patients that if they have something that doesn't seem right, a new cough, a new diarrhea, or any other symptom that seems out of the ordinary, they should seek evaluation immediately. And often that's in the form of an emergency room. And I recommend they go to a true emergency room at a hospital and not a standalone Instacare, where the facilities are better in terms of getting, imaging and rapid results from laboratories. Once that's been done, a diagnosis needs to be given. So depending on the patient's complaint and their symptoms and the imaging and laboratory results, a diagnosis can be given. If it appears to be an inflammatory process, the presumption is that it's immune-related adverse event, and depending on the grade, the severity of it, the amount of steroid can be administered. And the earlier that steroid is administered, the better chance that the patient will have resolution of their symptoms. In the lower grades, such as grade 1 or grade 2, you can temporarily withhold, or even grade 1, you can just continue patient on therapy with supportive care because it's so mild. Grade 2, you can temporarily withhold and then restart as their symptoms and laboratories improve. And then it's a decision of what dosage range of prednisone or equivalent to give, either the 0.5 to 1 mg per kg per day or the 1 to 2 mg per kg per day. And then once the organ system or tissue is identified, getting the specialist for that part of their care engaged and managing the patient. This is how I approach immune-related adverse events.